Although EGFR inhibitors, including afatinib, can be very effective, and this patient has a high chance of benefiting, and hopefully for a long time, we know that these drugs are not curative, and eventually the cancer progresses. And so at the time of progression, I always have to ask myself, how is the patient doing clinically? Because sometimes on scans, we can see tumor progression, but the patient's actually doing quite well still. And if the progression is minimal, we might be able to continue treatment for a period longer. So that's really the first question: do I need to actually switch therapies right then? So at the time when I feel that there is clinical progression and I do need to switch treatments, I will plan to get a biopsy of the tumor, and that's to look for a secondary mutation or the mechanism of resistance. After first and second generation EGFR inhibitors, so afatinib being a second generation inhibitor, we do see the development of T790M in EGFR about half the time. And so at that point, we're able to use a third generation drug like osimertinib, which can be very effective for patients. So I would consider that a standard of care at this point is assessing the tumor for T790M at the time of resistance. You could do that either by a tumor biopsy of a progressing lesion, or you could also consider a plasma biopsy, meaning liquid biopsy using plasma, which is a blood test. Sometimes I do both. So in a patient who has an easily accessible lesion, I'll consider a tissue biopsy. If it's difficult to do that, I'll get liquid biopsy with blood. They can be complementary, so I'll sometimes do both. If the blood is negative, I'll definitely really consider getting a tissue, because blood can have a false negative rate. But it's very important to know if a T790M is present, because osimertinib can be a very effective treatment, and if T790M is there. There are other mechanisms of resistance, and there are clinical trials assessing whether treatments can work for those. But in cases where T790M is negative, typically I would consider chemotherapy for patients after progression on a first or second generation EGFR inhibitor.